Well, as Kelly mentioned, we are extremely fortunate to have the partnership that we do with Adventist, and to take you through that and talk a little bit about some of the barriers and obstacles that live within the palliative care universe. Please give Laura Macias a wonderful welcome.
Thank you to Kelly for stepping in and pinch hitting. That was wonderful. I really appreciate it. So my name's Laura Macias. I'm a nurse certified in hospice and palliative care, and I'm the clinical manager for Adventist Health Options, which is one arm of our outpatient palliative care program. We also have a second arm with the OHSU Richmond Clinic, the Advanced Illness Care Program, and I work in partnership with Lisa Pearlstein to meet the needs of CareOregon patients at Richmond Clinic. So some of the take-home points I'm hoping that people will come away from this is remembering patients are people and people are complex. The story that we hear on our patients is going to change. It's going to change over time. It's going to change based on who they're talking to. Are they talking to their provider? Are they talking to a friend? Are they talking to a family member? The setting that they're in, are you talking to them in the clinic where maybe they had to really rush to get here, they're not very comfortable, they didn't take their diuretics because they don't want to pee, so maybe they're not breathing very well? Or are you meeting them at home in their place of comfort where they feel like they have a little bit of control and they may tell you more things than they do when they're in the clinic? I like to listen to what patients tell me, but I also like to listen to the things that they don't tell me. Sometimes not answering a question gives me just as much information as answering the question. If I ask you 3 different ways, did you weigh yourself, and you don't give me a direct answer, I know you didn't weigh yourself and you're probably not doing it on a regular basis. And then asking questions in different ways. I don't just go in and say, hi, how are you today? I follow that up with, how are you feeling? How's this going for you? Breaking it down into those individual parts of that person that make up the whole of them. Sometimes patients, they get smart and they don't want to answer your questions, so you have to figure out how you can get that information from them in kind of a backdoor way. So what is palliative care? I really like the National Consensus Project for Quality Palliative Care is defined this way. Palliative care means patient and family-centered care that optimizes quality of life. We want to anticipate and prevent suffering as much as possible. It's very easy for us as professionals to anticipate what suffering a patient might face as their disease progresses. So our challenge is to try to frame that information in a way that patient can hear it so that we can be planning proactively so that they're minimizing that suffering before it happens. I truly believe that palliative care is something that should be used throughout the continuum of illness. Now, right now, most of our palliative care services are definitely towards end of life, the last 1 year of life. But the concepts of palliative care can really be used from birth to death. So our health options program, specific goals for that program is to increase the patient and family understanding of their disease process. What do they understand about their disease process? I will ask them to tell me, what has your doctor told me? What do you understand? Because we know that what patients hear is not necessarily what we intend them to hear, and maybe not even be the message that we're trying to convey to them. I want that patient to clarify for me what are their goals. I know they're hearing what the doctor says, I know they're hearing what their family says, I want to know what they think is their goals for their care. Because the decisions that they make at the end of the day are more reliant on their goals for care than anybody else's. I also want to make sure I'm documenting and communicating to all of the other people involved in this patient's care so that when we're sitting at the table talking, we're on the same page of the same book and everybody's talking the same language. I can't tell you how much it can derail progress that you make with a patient if you haven't touched base with a provider and then that provider introduces a topic of conversation that really would have been best left unsaid. And it's closing that loop of communication in between all of those people caring for that patient. We also want to make sure that we're collaborating for timely and appropriate access to care. Does the patient really need to go to the emergency room if we can get them a same-day appointment with their provider? That's going to be a better use of their time and energy than sitting in the ER for 3 hours and maybe not getting really what they need at the end of that encounter. And we want to facilitate transition to hospice and or alternate level of care. And I really want to underscore alternate level of care is meaning any transition of care, whether that transition is from home to the hospital, hospital to nursing home to adult foster care. Anytime there is a transition in care, whether it's level of care or place of care, we need to make sure that we are collaborating and coordinating with all of those pieces involved. So these are the various team members. You have your primary care clinic and staff, the palliative care RN, and the palliative care social worker, who are quite often doing joint visits together so that they can identify both the medical and the psychosocial issues and kind of divide and conquer. Our home health aides are used on a as-needed basis as we're trying to get patients hooked up with aging and disability services. They qualify for home caregiving, but they haven't gone through the screening process. They haven't found a caregiver, so we're going to give them some in-home caregiving for a short period of time while those other pieces are being put in place. These are our primary interventions. We're educating about disease process. Educate, educate, educate. Educate, how much did the patient understand? Re-educate. Come back 2 weeks later. Are they remembering that information? Do we need to talk about it again? Goals of care and advanced directive completion. These conversations happen over time. We're not typically even going to start addressing this in our first visit, other than to get from the patient what is their goal of care. Planning for future events. Again, this is where we as professionals who have experience and understanding of how these disease processes typically work, we can look ahead and think, oh, I know they're going from stage 3 to stage 4, and they have this really chaotic home environment with very little caregiving. I need to start thinking about getting caregiving resources in now before the stage 4 gets here and they're in the hospital because they have nobody monitoring their weights or their sodium intake. Psychosocial support, not just for the patient, but also for the family members and the caregivers. And I really want to impress that upon everyone, because we're treating a whole group of people, not just the patient. We're also treating the people who are directly related to that patient and who are impacted by the changes in that patient's life. And then spiritual support, which I'm so happy we have some limited chaplains, because spiritual support is a huge issue for our patients. We in the medical community do a great job of looking at the physical. We're doing a better job of looking at the emotional, but the spiritual is still a realm that we kind of turf off to the chaplains. But it is a part of that entire person. So our outcomes are hopefully that the patient and family are going to have a better experience within the healthcare system. That the providers are going to feel like they really understand what's going on with this patient and people are working together as a team, and that there's going to really be a reduction in non-beneficial care that most often produces suffering. So back to our patient. When she met Jayne, she was 49. By the time she comes to us, she's 51. She's living with adult children. I'd like you to go back and think about her children. So she had 4 of them, 3 of them non-eventful pregnancies, but that 4th pregnancy, where she was pretty sick during most of that pregnancy and then sick for the rest of her life after that. So she's living with her youngest son, who's only known a sick mother. And now he's knowing a sick mother who he's being told is going to die. So she was referred to us in July. We didn't admit her until November. I'd like to say that that is something that doesn't happen often, but I would not be telling the truth, because engaging with our patients can be quite difficult. There's chaos in their lives. I think Jayne said it really well. Those HEF-PEF patients are chaotic lifestyles. Now, this was not a HEF-PEF patient, but she had a pretty chaotic lifestyle. I was reading through her chart last night, and part of the reason why we didn't engage her until November is she had a change in insurance, which meant we had to get her back on the right insurance. Then her house didn't have electricity, so we're trying to figure out where she could go. There was talk about maybe she was going to move to Salem, and if she was going to move to Salem, that was going to be a whole different plan of care. There was lots going on with this lady. So finally, we admit her. Not only does she have this pretty significant heart failure, but she's got these other things going on too. End-stage liver disease. She's been hospitalized a couple of times with encephalopathy. She's got to take her lactulose. She's got the chronic kidney disease. She's still smoking. She's got chronic pain issues, so she's on narcotics. And she's generally not adherent to the prescribed dietary changes. I think the way that one of the nurses documented, Mrs. J wants to pursue all treatments to cure her heart disease, while at the same time she continues to smoke and eat and drink what she likes. So the care team specifically for Miss J, her PCP was through the Richmond Clinic. So we, in addition to her PCP, we had some health resilience support. She had cardiology through OHSU, and then, yes, this health resilience specialist was because of her relationship with her PCP. Our home care team, so she had a nurse and a social worker through our health options, and then she had a home health aide until we got to getting her son as a paid caregiver, and then the home health aide stepped out of the picture. She had home health for a period of time. Their first were in there for strengthening and increased safety in the home, and then we went on to some infusion issues, which we'll talk about. And then last but not least, the Aging and Disability Case Services Manager, your go-to person for trying to get in-home caregiving. So barriers to care. She had limited phone accessibility, and she moved around a lot. She was at one son's house one week and another son's house the next week, and her oxygen concentrator was at a third residence that she was sometimes at. So supplies and everything for this patient were scattered all over the city. She was inconsistent with her caregiving resources. Son was a paid caregiver, but as I'll talk about later, his desire to caregive was always kind of questionable, so her caregiving was not always stable. There were times when she was symptomatic and she would decline home visits. And trying to talk with patients, I know you don't feel good, but I am a nurse, and one of the things I can do is maybe come and help you figure out why you're not feeling good and what do we need to do differently. But when people don't feel good and they have mistrust for the system, you're not always going to get there. So then there was patient and family priorities differed from the medical team. The family wanted all life preserving, everything done, keep her alive as long as possible. The patient stated that she also wanted the same thing, but her behaviors were not necessarily in line with that. So she would not consistently follow fluid and sodium recommendations. She continued to smoke tobacco, and we suspected also marijuana. And so she wasn't doing those behaviors that really were going to help improve her health, but she stated she wanted to do that. Healthcare barriers to care. So EMRs that don't communicate. Still haven't figured out an answer to this one. If I do, I'm not going to tell anybody because I'm going to get really rich on it. Poor inter-team communication. And this came in really early in our time with the patient. This is when the providers had not all sat down to have a consistent message with what information we're going to present to this patient. Our social worker went to meet the patient on the unit, and the patient said, "The doctor just told me I could have a heart transplant." So that really kind of put us in a place where we had to back up and have some more family conferences to figure out really what is an actual intervention this patient can have. So it's really important that all those providers are giving the same message. And then lack of systems for facilitating timely communication to hospital admission. I am so happy to say that this particular barrier has been resolved. We now have access to pre-manage, which is a system that gives us real-time information if patients register in either the emergency room or as an inpatient in the hospital. So every day I'm in my computer checking and getting those notifications and then notifying the team, hey, so-and-so's in the emergency room. Please reach out to the discharge planner, find out if they're going to get admitted, let them know what's been going on in the house. So that part is definitely improved. Who is doing what? Also known as care coordination. One of the big things that we're doing in palliative care. So the health options nurse, the primary role of the nurse is to evaluate the patient's and the family's understanding of the treatment plan. Do they understand the treatment plan? Do they even know what the treatment plan is? Are their goals for treatment the same as the provider's goals for treatment? Maybe they haven't had the courage, I don't know that that's a great word, to be honest with their provider about the burden that some of these treatments put on them. But they have a really good relationship with that provider and they want to keep that provider, and so maybe they don't tell the provider that their goals have changed because they don't know how to. So trying to elicit that information from the patient. Then collaborating with that medical team to tell them, hey, did you know this patient actually thinks this is what's going on? And that's why they're not taking their water pill. I apologize, I'm not coming up with explicit examples, but I get a little bit of stage fright standing in front of a big group of people. So really understanding what is that patient's goal, because we know that the decisions that they make on a day-to-day basis are really driven by their personal goals more than anything else. So then once we uncover those discrepancies in their understanding of what's going on, we need to go back to the medical team so we can do some re-education. Sometimes the education can come from a nurse and it can be taken, but quite often that education about prognosis and where they're at in their disease trajectory needs to come from the physician if the patient is really going to take that information in and believe it. We're coordinating with the social worker and the home health aide who are also seeing the patients to make sure we're getting their aspects of information so that we're getting a coherent picture that we're communicating to the care team. And then coordinating communication between inpatient and outpatient care teams. You know, the hospital is a train on one track, and outside of the hospital is a train on a different track. And they pass each other a lot, but they're not often sharing information. And so we're trying to build some bridges between those trains and make sure that information is flowing back and forth so that this plan of care is as seamless as it can possibly be. The social worker is evaluating patient and family psychosocial barriers to accessing care and resources. They're going to coordinate caregiver support. They're going to help get that screening appointment scheduled. Maybe if the patient lives by themselves, they're going to be there during that screening appointment to help the patient answer the questions so that they can get the help that they need. Because if they don't answer the questions right, they're not going to qualify for the caregiving. They also provide guidance and support and educate the patient and family on how they can access resources. So they'll role model. They'll call medical transport and show the family and patient how it's done. They'll do that a couple times and then they'll say, it's your turn because you're going to take this over as part of becoming a patient caregiver or part of becoming a patient. You need to take on this task. We're also going to provide guidance and support to them as they're navigating this system. We all know the healthcare system is a beast. I mean, we're professionals, and I don't know about you, but sometimes I want to beat my head against the wall when I'm talking to my pharmacy to understand my pharmacy benefit. And these patients, they don't have our education and experience with the healthcare system, and they don't feel good. And we're asking them to do a lot of tasks that take time and energy that they really don't have. So coping with the changes that come when they're feeling sick and not feeling well, our social worker is going to be helping with that. And then, of course, coordinating communication between inpatient and outpatient care teams. Communication, communication, coordination, coordination. That's a lot of what we're doing. So, Mrs. J's story. The first couple of months she was on service. It was a little bumpy. She was allowing visits, but within the first month, she was back in the hospital. Even though we got caregiving established and we got transportation established, she got admitted to the hospital because she got fluid overload. She wasn't really following what she needed to do. This was a big goals of care conference during this hospitalization where we explicitly communicated to the patient and her family that she was at end-stage disease, that a transplant was not an option for her, and that we really needed to focus on other ways of modifying her disease. So she went back home and she let staff come out. She let health options come out and she let home health come out. So there was a lot of people in there with eyes on her. And during that time, she seemed to improve. She was making it to the clinic for appointments, not every appointment, but most of them. So that was an improvement. She eventually was discharged from home health because she was getting stronger and she met her home health goals. She was up cooking for her family. She could do it with minimal shortness of breath. She was really in a good place. Our health options visits continued until she was admitted to Adventist AMC ICU for general weakness and chest pain. There was a huge patient care conference in Adventist Medical Center. At this time, the patient was on a dobutamine drip. And it was determined during this conference that she really couldn't come off the dobutamine drip and survive. The patient and her family wanted everything done, so based on that care conference of wanting to have all available life-sustaining treatments, she was transferred up to OHSU. I believe OHSU had been on divert, and that's how she ended up at Adventist. So she ended up staying at OHSU for quite a period of time. We actually discharged her from our services because she was on the dobutamine infusion and she couldn't come off the dobutamine infusion. And at that time, the only place that the dobutamine could be given was in the hospital. So it was decided she's going to be here for a period of time. We discharged her, but we continued to remain in contact with the staff. and touch in with them on a regular basis to understand, because we knew if she didn't die in the hospital, eventually she would be discharged and we would want to continue with supporting her. So there eventually was an ethics consult and a goals of care discussion. OHSU discharge planners had looked far and wide trying to find a skilled nursing facility that would take her with the dobutamine infusion. Couldn't find one that would take her. She really wanted to go home with family members providing caregiving. Family members wanted her home. What was really interesting to me as I was reviewing her chart yesterday was that the one person who was not present at this goals of care discussion was her son, who I'm going to call Jason, because Jason is easy for me to remember. He wasn't present at this conference, and he was the person who was going to be her primary caregiver, the paid primary caregiver. So after this, it was decided we're going to get her on home health to manage the dobutamine infusion, and we're going to send her home with home health, health options, and supporting the family caregivers. So we got everything together, we got her home, and she came back within less than 24 hours. The son wasn't really there, wasn't really desiring to be there or to be helpful. She became confused and she had a non-injury fall, so she ended up back in the hospital. We quickly identified additional caregivers, got them trained, and then we were able to discharge her home with these additional caregivers. And that period of time, from my observation, was actually kind of the best time. She had a caregiver who was really vested in helping her. This was not a family member, it was a friend of the family, but this woman was all over it. She was making sure the weights were being checked, she was on top of the diet, she was really there. And at the same time, Mrs. J was starting to go through the emotional process of accepting that her life was coming to an end. She did, in one discussion in home, say that her ultimate desire would be to die at home, but this was obviously causing tension between her and her son, who did not want to come home and find his mother dead, who did not want to watch his mom die. He'd seen her sick his whole life. This was not how he really wanted things to go. So Mrs. J then kind of stopped talking to us about it. We would go see her, she'd be doing okay at home, she would go to clinic appointments, and in clinic appointments she would talk about how, oh, maybe I don't want to do this anymore, maybe I do want to go to hospice, maybe I want to think about these things, but anytime we would talk about it in front of family members, nope, I want to do everything, I want to stay alive as long as possible. Ambivalence, I mean, we all have ambivalence. This is a big change in her life, and she has to make a decision about it. And that's hard when you have different people communicating different things to you, and some of those people you love and you don't want to let them down. So in our visits, what we really tried to focus on was helping with her and her family to do some goal planning. We did complete an advanced directive, which at that time was full code. I'm sorry, a POLST. We completed a POLST. Advanced directive we kept having conversations about. So despite all this discussion and despite the patient saying one thing, she ultimately decided to remain a full code, and we honored those wishes. Well, as we're getting farther along into our time with Mrs. J, we had a breakdown in caregiving. And this first came to our attention when we found out that she had driven herself to Lowe's, and after shopping at Lowe's, her ICD-9 fired and she collapsed and 911 was called. So then we find out she's spending a lot of time alone, which really is not what we wanted for her. And she's driving. She's on a dobutamine infusion and she's driving around town. I don't know about you, but I don't really want other drivers on dobutamine infusions. I don't think that's great. So we had some pretty conversations, but she still wanted to remain full code. We were having caregiving breakdown. This lovely woman was getting pushback from the patient's sons because even despite all of this, she's still very sick. And her heart disease is still progressing because she's not perfect. She still overdoes the salt sometimes, she still overdoes the fluid, and she's still smoking. So her disease is still progressing, and her sons are seeing this, and they're putting blame on the caregiver. So the caregiver ended up quitting because of tension with the sons. So they started to notice that she was deteriorating in her physical appearance. I mean, we suspected there was caregiving issues, but whenever we would talk to the patient about it, everything was fine at home. She also seemed to be reporting a lot more fear and anxiety when she would go to the providers, which was pretty much the only appointments where she didn't have family with her. because anytime our staff was seeing her at home, there was a family member there. She was making some efforts to stop smoking. She started using the patch. This is when I knew that she understood how serious this was. She had not been tracking her weight and fluid intake, but started making some effort to do that. But she consistently did not want to move to a higher level of care or change her code status. However, she was living how she wanted to live. Half the time we couldn't see her because she was gone somewhere visiting somebody. We'd call, we'd have a scheduled appointment. Oh, I'm going down to Salem to see my sister. So she'd go down and do that. So on the one hand, she was doing things that she enjoyed. She was trying to live the life she wanted. But was that really consistent with her stated goals? No, not really, it was not. So after driving again, she got admitted again. And we had to have another conversation about what are we doing here and what are our goals? Because with this dobutamine pump, you know, we really need to be a little bit tighter with fluid and with sodium and with not smoking. And with having caregiving there to help her at home so she's not by herself. She continues to decline to move to a higher level of care, but our social worked with her PCP to try to get Life Alert in the home so she could have emergency contact and just shore up as much of those in-home caregiving resources as we could. She starts having more symptoms with nausea and vomiting, not well managed. As her heart disease is progressing, that's what we expect to see. Now she's progressively gaining weight with increasing abdominal girth, because this is where all of her weight would come into her belly, and then that would affect her breathing and her mobility. She had a complete breakdown in in-home caregiving. Her son just stopped. He just stopped being emotionally present and stopped helping her. His girlfriend got pregnant, and he told his mom they were going to move out and she was going to have to live by herself. So she was really struggling to manage all of the details of her needs. And she was continuing to be ambivalent about what she really wanted. There was one appointment with a provider where she talked about going and touring Hopewell House because she thought Hopewell House might be a nice place where she could go and die. But then if we would try to bring up the discussion about hospice transition in front of the family, nope, I don't want hospice. That's not what I want. So she had multiple hospitalizations because she couldn't keep the fluid off. She continued to remain full code, and if she would discharge home with caregiving. We had several care conferences with the medical team and family. The family would see signs that they would interpret as the patient was getting better. They could get some fluid off of her in the hospital because they could control her diet, and she could get up and walk around with less shortness of breath. So the family says, that's wonderful. Keep doing that wonderful work. We know you can make it work longer. So because she chose to remain full code, and because of the high acuity of interventions that were needed, she basically had to stay in the hospital. So she was in the hospital. We communicated regularly with the team. This incident here, patient coded and intubated and taken to ICU, occurred while her health options social worker was there talking to her about her goals of care. She reaffirmed to the social worker that she wanted to do everything possible to save her life. She wanted to live as long as she could. The social worker stepped out of the room and she coded. And they took her to ICU. And that was the last time that any of our team had a conversation with Miss J. Because she was in ICU and intubated and unable to direct her care, a care conference was held with her sons. And her sons at that time were agreeable to withdrawing life support, and she died at the hospital. So in the 12 months that she was connected with health options, we had 6 case care conferences, 2 team meetings, 1 ethics consultation, and about 180 touches by the palliative care team. She was able to be home for quite a significant period of time, from May to October, where she did things that were enjoyable to her. She was driving, she was going to visit family. She was trying to have as best quality of life as she could with the decisions she was making for herself. She received patient-centered care with interventions that were driven by her goals and desires, as she was willing to state them and document them within her medical record. So how did we impact her care? We were able to clarify what was going on at home. We suspected at times what was going on at home, but having a nurse and social worker there, seeing what she was eating, seeing the marijuana and cigarette paraphernalia throughout the house, could gain a better understanding of what was actually going on in the house. Were able to gain an understanding of how that home situation was affecting the decisions she was making in the care that she was seeking for herself. We were able to continue educating and clarifying the expectations with the patient and the family about what was realistic. Did they always hear what we had to say? No, but we continued to offer that teaching. We really did, I think, streamline and clarify inter-team communication. After that hospitalization where transplant was discussed, I see in the record a lot more emails back and forth of people communicating and talking about conversations that happened in this appointment, so make sure that we're reinforcing this message. And that was all wonderful. And while the final outcome may not have been ideal from the perspective of the medical team, it did meet the patient and the family's needs for how care should happen. And at the end of the day, if we can't meet the needs of our patients and family, what are we doing? So the take-home points, family dynamics. Family dynamics are everything. They really are. This patient was making decisions because of the family dynamics. She recognized that to some degree she had let her children down, and she wanted to take that control back and try to be a good mother and do everything she could to live as long as possible. Things are not linear. And Jayne showed a couple of slides. You know, you go for a while, and then we go down here, then we go down here. Sometimes we go back up there. It's all over the place. You have to figure out where the patient is in that moment that you're talking to them and make the decisions and the interventions that are going to work best in that moment, and understand that when you see them next week, this whole thing might change again, because they might change and be in a completely different place. So it's messy. It's messy. But it really does take a village. We all have to work together as a team. No one person can do it all, and no one person should do it all. We should be working as a team, because humanity grew up and evolved in groups of people helping each other. And that's how we're going to continue to help each other, as groups of people. And now I think we're at the point where we will take questions.
Wow, fantastic. Laura.